This is the CJSON podcast. My name is Benjamin Adegbite, a resident physician from Mount Sinai.
And my name is Evren Azeloglu, an associate professor of medicine in the Division of Nephrology at Mount Sinai.
Today, we will talk about our study titled Patient-Specific Pharmacokinetics and Dasatinib Nephrotoxicity that is coming out on CJSON.
A few years ago, we identified dasatinib as the tyrosine kinase inhibitor with the highest reported risk of glomerular nephrotoxicity. In that earlier study, which was published in 2019, we used meta-analysis of the FDA Adverse Event Reporting System to evaluate the relative nephrotoxicity risk of dasatinib use. From this initial study, we learned that dasatinib may have a direct effect on glomerular injury rather than secondary to hypertension, as it was not associated with higher risk of high blood pressure. The direct glomerular injury hypothesis was further supported by the fact that only dasatinib and none of the other comparable tyrosine kinase inhibitors caused actin cytoskeletal defects and effacements in podocytes, both in vitro and in vivo. In addition, there have also been case reports of reversible albuminuria in patients using dasatinib. Thus, we decided to develop a study to systematically investigate dasatinib's glomerular toxicity.
We recruited chronic myeloid leukemia patients who were undergoing tyrosine kinase inhibitor treatment for at least 90 days prior to recruitment. 82 participants were recruited from the Memorial Sloan Kettering Cancer Center and the Tisch Cancer Institute at Mount Sinai in New York City. We collected and analyzed urine samples for all participants and also plasma from participants taking dasatinib. We first wanted to determine if albuminuria was more frequent in the dasatinib cohort compared to the non-dasatinib cohort, which comprised of patients taking any of the other tyrosine kinase inhibitors. We also wanted to find out what factors could increase one's risk of developing albuminuria while on dasatinib. As such, we looked at associated clinical metrics and performed pharmacokinetic analyses in order to see if plasma concentrations had any effect. Our study also featured a brief case report on one of our participants who was noted to have severe albuminuria while on dasatinib. The participant was subsequently biopsied and discovered to have global podocyte field process effacement. However, after stopping dasatinib treatment, her kidney function significantly improved in a matter of months. We noted that this reversibility of kidney injury was also seen in our earlier published animal studies. Overall, the results of our study indicate the need for monitoring of kidney function while patients are taking dasatinib. Our results show that half of patients receiving dasatinib had at least moderately increased albuminuria, with 10% having severe albuminuria. Despite its limited sample size, our pharmacokinetic analyses show that plasma concentration of dasatinib was associated with the risk of developing albuminuria. In addition, there was more glomerular dysfunction with higher dasatinib dosage or longer treatment duration. We hope that our findings will spur on additional adverse event monitoring for dasatinib patients and inspire logical clinical studies. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.